দুটো কি তিনটে?
You must be knowing already. So here we are doing the sagittal section of the rectus abdominis. Okay. Based on this, we'll discuss the rectus sheath and its contents. Okay. Because you already know very well. Okay. First of all, the rectus sheath contains an anterior wall and a posterior wall by means of three muscles. What are those? External oblique. First of all, external oblique, and then followed by internal oblique, two lamina, and transverse abdominis. Okay. Here will be the rectus abdominis in cross section. So this is the cross section, for example, and this is the sagittal section, for example. Cross section is horizontal section. Okay. So here this is the anterior aspect. This is the posterior aspect over here. Okay. So anterior wall of the rectus sheath, posterior wall of the rectus sheath over here. Okay. So the first muscle, first aponeurotic part is by means of external oblique, and then this part is the middle portion is the internal oblique part, which is divided into anterior lamina. Lamina means, or lamella you can say that, like a membrane. Like a membrane. Okay. Anterior lamina or anterior wall, nothing but the internal oblique, and then one more posterior wall, posterior lamella or lamina, nothing but the again internal oblique over here. External oblique, internal oblique on the anterior wall, internal oblique and transversus abdominis on the posterior wall. Getting it down? So the division occurs, that means the two lamina are the parts of internal oblique muscle over here. Getting it out? Right? Right. So this is the posterior wall of the rectus abdominis, rectus sheath over here. This is the anterior wall of the rectus sheath. In between these two anterior and posterior walls, there is a muscle called the rectus abdominis over here. Okay. So in sagittal section, if you see the same thing, in front will be two layers, behind will be two layers again. In the upper part, external oblique aponeurosis, and then followed by the anterior lamina of the internal oblique aponeurosis over here, and then behind again internal oblique aponeurosis, posterior lamina, and then followed by the transversus abdominis, and even behind will be the fascia transversalis over here, normally, for the abdomen, with respect to the abdomen, okay? So the extents, you know, external oblique on the anterior wall, it will be extending from which costal cartilage? Fifth costal cartilage. Fifth costal cartilage till the pubic symphysis. Okay. Fifth costal cartilage till the pubic symphysis. Okay. The anterior wall, nothing but the anterior most layer, nothing but the external oblique. And then that will be the internal oblique. Internal oblique will be extending in between pubic symphysis and costal margin. Remember that problem. For example, if this is the external oblique, it will be, that means aponeurosis, it will be this long, the longest one, and then internal oblique will be, above it will be deficient and below it will be deficient. Similarly with the transversus abdominis also. Getting it down? So this is the entire external oblique aponeurosis. Above it will be continuous, below it will be continuous. And below, the internal oblique and transversus abdominis will be, above it will be deficient because these are ending at the level of the costal cartilages over here. And below it will be deficient over here because this will be shifted onto the anterior aspect over here. Getting it out? So this is that shift over here. So external oblique, internal oblique, anterior lamina, till the in between the umbilicus and the pubic symphysis. Getting it out? But on the posterior aspect, in between the costal cartilage and the pubic symphysis, and then on the posterior aspect, this posterior wall will be extending between costal cartilage till the junction between the umbilicus and the pubic symphysis over here on the posterior aspect in the form of an arcuate line in this manner. Do you understand? Arcuate line in the posterior aspect. Okay. So this is the entire posterior wall which is deficient over here. This small part will be shifted onto the anterior aspect in this manner. Now how many layers we can see that? 1, 2, 3 and 4 layers of the rectus sheath which are present over here. Getting it out, right? Right. So let us say the thickness of the anterior wall of the rectus sheath. Above it will be thinner, you can see that only one layer is present. And in the middle, in between the xiphisternum and the umbilicus, it is thicker. And below here, in between the junction between the umbilicus, in between the midpoint between the umbilicus and the pubic symphysis and the pubic symphysis, this wall is the thickest. You can see the layers, okay? This is one layer, this is 2 layers, and this is 4 layers over here. So thickest anterior wall of the rectus sheath is present in between the midpoint between the umbilicus and pubic symphysis and the pubic symphysis over here. Understood or not? At the same time, this part will be thinner over here towards the posterior wall. Get it done? And thinner above, and middle will be thicker over here. Got it down? Okay, easy to understand, right? So this is the anterior wall and posterior wall of the rectus sheath over here. Okay. So now let us see the contents. So one more thing. These are the tendinous intersections. You can see that. Actually, this much space will not be there, but to make you understand, the space has been created. Okay. But this part will be this much, very much close to the anterior surface of the rectus abdominis. Okay. And you can understand from this inner aspect of the anterior lamella of the internal oblique, there will be connection in between the muscle and the aponeurosis over here. These are nothing but the tendinous intersections. Okay, what is that? Tendinous intersections to give the strength to the muscle. Do you understand? To give the strength. For example, this part of muscle will be more stronger compared to the entire muscle. Getting it out? Right? So this part of muscle, this part of muscle, this part of muscle, this part of muscle will be acting individually, and that will be giving more strength to the rectus abdominis. Okay. What is the action of the rectus abdominis?
It's a flexion of the vertebral column.
Flexion of the vertebra or trunk.
Depression of the
What? Compresses abdominal contents so that expiration can happen. Is it not? Okay. So what is happening over here? Rectus abdominis. This is the trunk over here. What are the actions we can produce with the trunk? This is the flexion. This is the extension, and this is the lateral flexion, and this is the rotation. Is it not? We can do all the things. Okay. So this extension will be produced by erectors, spinae, multifidus, and all those things, back muscles. The flexion will be produced by rectus abdominis. And who will produce the rotation? In this manner.
transversus abdominis.
Obliques and transversus abdominis from one side. If they act on one side, they will be contracting in this manner. So trunk will be rotating in this manner. Getting it or not? So this rotation is produced by obliques and the transversus abdominis. Okay, we will discuss that later tomorrow. Okay. So rectus abdominis will be producing flexion because it will be pulling, because the origin is from pubic symphysis and pubic crest. The rectus abdominis will be having how many heads? The rectus abdominis will be having 2 heads in this manner. See, the rectus abdominis will be having 2 heads. One is the medial head, one is the lateral head over here. Medial head will be arising all the way from the pubic symphysis over here. Okay, upper margin of the pubic symphysis. You understand, right? And the lateral head will be arising from pubic crest till the pubic tubercle. Okay, so simply the pubic crest and pubic tubercle will be giving rise to lateral head, and the pubic symphysis will be giving rise to the medial head. Getting it all right? Okay. So these 2 heads join together and form a muscle called the rectus abdominis over here. Above this will be attached to. Above this will be attached to. Above this will be attached to which thing?
Anterior hand. Anterior side will be.
See here, above it will be attached to which structures you can see that 5th, 6th and 7th costal cartilages and also partly to Xiphisternum on the anterior aspect of it. So these are the 3 horizontally directed insertions of the rectus abdominis. Origin will be from below and insertion will be from above over here. So that's why from the origin the action will occur towards the insertion. So origin will pull the insertion so that flexion will occur. Could you understand? Generally from the origin to the insertion the action will occur. But from insertion to origin also the actions will occur. Any examples you know?
In case of push-ups,
Push-ups.
biceps are
Internal intercostal also.
Biceps. So whenever you're doing push-ups, which muscle is acting over here? What you are doing? Push-ups you are doing like this. So what is this action? This action, what is this action? Of elbow joint. Extension. Extension is done by triceps. So that's why you build up the triceps muscle in push-ups. Okay. So for example, in case of intercostal muscles, for example, external intercostal, internal intercostal, and transverse abdominis. Sorry. Intercostal is intimus. Okay, or innermost intercostal. So external intercostal will be acting from origin to insertion. So from external oblique in this manner. In this manner?
Yes, sir.
External intercostal in this manner. Okay. That will be pulling up the ribs in this manner. From origin towards the insertion in this manner. So lifting up the ribs, thoracic cavity, so that inspiration can occur. The rest of the muscles will be doing expiration in this manner. So from the insertion towards the origin, they will be pulling the ribs downwards in this manner. In this manner. So thoracic cavity will be reduced over here, so that expiration will occur. Could you understand? Okay. In the same manner, the pectoralis major, if you stretch and fix the insertions over here, these pectoralis major will be lifting up the thoracic cavity in this manner. Getting it out? Normally, pectoralis major is for adduction and medial rotation and everything, whatever it might be. Okay. But if you fix the insertions, the pectoralis major will be acting from insertion towards the origin. So you are fixing the insertion over here, so the origin will move in this manner. So will be acting as an accessory muscle of respiration over here. Could you understand? Right? So in that manner, the action will be occurring from insertion to the origin also. Okay. So from the origin towards the insertion, the action will occur. So this part will pull this part. So the flexion of the trunk will occur over here. Getting it? Right. So these are the slips of insertion into the 5th costal cartilage, 6th costal cartilage, and 7th costal cartilage, lateral to the medial, and finally to the xiphisternum over here. So this is the horizontal insertion in this manner. Getting it? Right. So one more muscle over here, that is nothing but the pyramidalis muscle that will be arising from pubic crest and pubic symphysis again, and that will be in this manner. So pyramidalis muscle is a small muscle which is pyramidal in shape, will be arising again from pubic symphysis and the pubic crest over here, and the base will be over here. Apex will be attached to the linea alba. Okay, here will be the linea alba, isn't it or not? The linea alba is nothing but intersections on either sides, the aponeurosis coming on either sides, that will be interlacing. Okay, interlacing over here. There will be the muscle, the aponeurotic fibers will be interlaced with each other. You are putting a lace to the shoes in this manner. So the same as the interlacement. That means this aponeurotic fibers are continuous with that side, and this aponeurotic fibers will be continuous with this side. Okay, they will be interlaced with each other. Getting it? So this interlacement in the middle it is called the linea alba. Okay, so linea alba will be extending in between xiphisternum and pubic symphysis in this manner. Okay, above the end will be the xiphisternum, tip of the xiphisternum, and below will be the upper margin of the pubic symphysis over here. Okay, this is the linea alba. Okay, which is the interlacement of the two aponeurosis on either sides. Okay, right. Into this linea alba, this pyramidalis muscle will be inserted over here. So again, the origin will be from pubic symphysis and crest over here, and the insertion will be at the level of linea alba. Getting it on? Right. Okay. So, coming to the anterior wall, this is the anterior wall of the rectus abdominis, which is adherent with the anterior lamella of the internal oblique over here. Get it? On the posterior aspect, there is no tendinous intersections over here. So the posterior wall will be absolutely separated, easily separable from the rectus abdominis posterior wall over here. Do you understand? Right? So here you will get the two vessels. One is from, what is that? Superior epigastric artery, and one is nothing but the inferior epigastric artery. This is a superior epigastric artery. Superficial is different from superior, right? Superior epigastric artery is a branch from the internal thoracic artery or internal mammary artery. Okay. This superior epigastric artery will be entering into the posterior aspect of the rectus abdominis through a space called space of larynx between these two. Getting it or? So there is an origin of the diaphragm from the 7th, or for example, if you take the origin of the diaphragm in this manner, for example. So this is one origin, and from the 7th costal cartilage there is one more origin of the diaphragm over here. There is a space called space of Larry over here. Could you understand? Behind the rectus abdominis over here. Through this space, the vessel will be coming out towards the posterior aspect of the rectus abdominis. Getting it over? So this is that space of Larry over here. For example, this is the 7th costal cartilage. For example, here will be the xiphisternum over here. So these two are the origins for diaphragm in this manner, for example. Getting it over? So this is the entire diaphragm over here. So this space is called the space of Larry, through which the superior epigastric artery will be entering into the posterior aspect of the rectus abdominis over here. Getting it over? Right. So this is the space of Larry, and this is superior epigastric artery going within the substance or behind the rectus abdominis in this manner. Getting it over? So within the substance of the muscle or behind the muscle over here. It will be reaching the umbilicus and anastomos with the inferior epigastric artery. Inferior epigastric artery will be piercing the fascia transversalis over here, because see here, The posteriormost layer is the fascia transversalis over here. Okay. So at this point, there is only fascia transversalis at the posterior wall of the rectus shikhar. So by piercing this initially, this part will be having fat, nothing but the extra peritoneal fat. For example, there is a peritoneum which is situated in this manner. For example, the wall of the abdomen is lined by peritoneum in this manner. Okay, peritoneum. This is the peritoneum, which is a visceral layer equivalent to the pleura. Pleura structure and peritoneal structure are similar. Serous layer means what? Serosa means what? It is made up of
watery secretion.
squamous epithelium and of course loose areolar tissue. Squamous epithelium, loose areolar tissue. Okay. So on which side, for example, if you take the pleura, on which side the loose areolar tissue must be present, on which side the epithelium must be present.
Epithelium is the outer side.
For example, these are the two pleural layers, for example. For example, this is the lumen in between the two pleural layers. This is the outer aspect, okay? This is the lung substance and this is the outer aspect, endothoracic fascia and everything. So if you take one layer, parietal layer, to which side the epithelium will be directed and to which side the areolar tissue will be directed? Epithelium will be directed outside. Outside, Pakka. That is the difference. See here. For example, this is the pleura over here. See here, this is the two layers of the pleura over here. This is the visceral layer, this is the parietal layer over here. So this cavity is nothing but the pleural cavity. Pleural cavity will be having fluid, pleural fluid. From where the pleural fluid is released over here? Obviously, the epithelial cells, isn't it? Okay. So epithelium must be directed towards the lumen over here in this manner. And the loose areolar connective tissue will be directed outside the lumen over here. Getting it out? So this is the structure. In case of peritoneum also, on which side the peritoneal cavity will be having peritoneal fluid. So to which side the epithelium is directed? For example, this is the anterior abdominal wall over here, and this is the abdominal cavity over here. So this abdominal cavity will be having peritoneal fluid, little bit amount of peritoneal fluid, just like the pleural fluid also. So to which side the epithelium is directed? Towards this side or towards this side? Towards this side. Is it not? So the epithelium will be directed this way. So that will be releasing the peritoneal fluid in the peritoneal cavity. Getting it out? And this part will be the, what is this? Fascia part. So that's why this fascia is having this extra peritoneal fat. Because the fascia will be having the peritoneal fat, not the epithelium. Could you understand? Right? So, in between the fascia transversalis and the peritoneum over here, there is the adipose tissue over here, which is called the extra peritoneal fat. Outside the peritoneum is the fat. Okay? So, behind this fascia transversalis, there is the extra peritoneal fat. So the inferior epigastric artery initially will be lying at the level of the extra peritoneal fat over here. Then at this level, at this lower part, it will pierce the fascia transversalis because there is no posterior wall over here, and then enters into the posterior aspect of the rectus abdominis over here. Getting it out? So the superior epigastric artery passes through the space of Lavi, but the inferior epigastric artery initially it will be in the extra peritoneal fat over here. Then pierces the fascia transversalis and passes deep to the arcuate line over here and enters into the posterior aspect of the rectus abdominis. Could you understand? This is the posterior wall over here, where the arcuate line is the end for the posterior wall. Is it not? Is it not? So in between the posterior wall and the rectus abdominis muscle must be the inferior epigastric artery. So this inferior epigastric artery must be passing deep to the arcuate line and enters into the posterior aspect of the rectus abdominis. Could you understand now? Okay. This alignment is very much important. Okay, do you know it? So superior epigastric artery through the space of Lavi will be asked in the examination, and then followed by the inferior epigastric artery, which is the branch of external iliac artery. This is iliac artery, so common iliac artery. External iliac artery gives rise to inferior epigastric artery. So this external iliac artery, internal iliac artery are present in the abdomen. Is it or not? Which is the branches of the common aorta, abdominal aorta, right? So this is present in the abdomen over here. Okay. So within the abdominal cavity or pelvic cavity, you can say that these two vessels are present. So to go towards the anterior aspect, towards the anterior wall of the abdomen, it should go all the way from abdominal cavity, then passes through the peritoneum, enters into the extraperitoneal fat. Not through the peritoneum, outside the peritoneum, it should enter into the extraperitoneal fat, and then enters into the posterior aspect of the rectus abdominis after piercing the fascia transversalis and passing deep to the arcuate line over here. Could you understand that? Right? For example, this is the arcuate line and this is the posterior aspect of the rectus abdominis. Okay, this is the end of the posterior one. And this is the extraperitoneal fat. The vessel is initially present over here, extraperitoneal fat, and pierces the fascia transversalis and passes deep to the arcuate line, then only enters into the posterior aspect of the rectus abdominis. Understood or not? Right? So this course is very much important. Getting it all right? So and one more thing you're supposed to remember, for example, the peritoneum is in this manner. This is the anterior abdominal wall, this is the posterior abdominal wall. And this is the peritoneum, lying in the posterior wall and the pelvic cavity and the anterior wall over here. Okay? And the external iliac artery will be present in this manner. Abdominal aorta dividing into common iliac arteries, again dividing into external and internal iliac arteries on either sides. Okay? For example, this is one external iliac artery. The external iliac artery will be giving rise to inferior epigastric artery that will be passing within the extraperitoneal fat and pierces the fascia transversalis over here and then enters into the rectus abdominis. Could you understand? Right? The arteries are outside the peritoneal cavity. Getting it all right? So this is the posterior abdominal one, this is the vertebra for example. This is the aorta dividing into two common iliac arteries and external internal iliac arteries. External and internal iliac arteries over here. So this part is the lower limit of the peritoneum over here. So the vessels are outside the peritoneum. Getting it all right? So if the external iliac artery, external iliac artery gives rise to inferior epigastric artery, this artery will be running outside the peritoneum, not within the peritoneum. So here we will be having the extraperitoneal fat over here. So the inferior epigastric artery will be passing through the extraperitoneal fat over here. Do you understand? Okay. So this part will not be present, for example. So this is the extraperitoneal fat where the inferior epigastric artery is present. And piercing the fascia transversalis enters into the posterior aspect of the rectus abdominis after passing deep to the arcuate line over here. Everybody could understand or not? Right? Okay. This inferior epigastric artery which is entering in this case, for example, there is a small relation which you are supposed to know. There is a ring called deep inguinal ring. What is it? Deep inguinal ring over here. Okay. This deep inguinal ring, for example, this is the fascia transversalis over here. This fascia transversalis will be having this deep inguinal ring over here. Okay. Deep to the fascia transversalis is the inferior epigastric artery. You can understand now, right? So this is the fascia transversalis horizontally going behind all the obliques over here. Okay. So within the fascia transversalis, there is a ring called deep inguinal ring. Superficial inguinal ring we have already seen. Where it is present? External oblique towards pubic crest, over the pubic crest, ending at the level of the pubic tubercle. So that will be present over here. Okay. This is the superficial inguinal ring, and this is the deep inguinal ring through which passes. Which structure will pass with? Absolutely. Spermatic cord in case of males and round ligament of uterus in case of females. Getting it on? So the testis, for example, it is present over here. Testis it is present over here. For example, testis it is present over here. This part is the scrotum over here, for example. So vas deferens will be going over here and goes behind. The same manner, the round ligament of the uterus will be coming all the way from pelvic cavity and passes through this deep ring and superficial ring towards the labia majora over here. We will be discussing that later. But the thing what you are supposed to understand is this is the deep ring, inguinal ring, and this is the superficial ring, and this is the inguinal canal over here, which will be lying just above the inguinal ligament. We will be discussing tomorrow. Okay. So there is a deficiency over here within the fascia transversalis. Is it or not? So there is a deficiency within the fascia transversalis. For example, this is the fascia transversalis. There is a deficiency. Okay. So through this ring, the abdominal contents like the intestines or peritoneum or anything, peritoneal fat or anything, can be herniated through this tract and enters into the scrotum over here, or into the towards the labia majora over here in case of females. Okay. So if any hernia occurring through this ring, through this ring is termed as indirect inguinal hernia because it is not passing through the abdominal wall muscles over here. If any hernia passing through the abdominal wall muscles, that is called the direct hernia. But if it is not involving any abdominal muscles, that is called the indirect inguinal hernia. So indirect inguinal hernia will be passing through the inguinal canal and enters into the scrotum or labium majus, whatever it might be. Okay. So this inferior epigastric artery will be used as a guide to understand whether it is direct inguinal hernia or indirect inguinal hernia. Okay. If the hernia is occurring through this part, the hernia is occurring through this part over here, then it is called the direct inguinal hernia. And if the hernia is occurring through this part, that is called the indirect inguinal hernia. Getting it on? Because here will be lying the abdominal wall muscles over here. Getting it on? Right? So external oblique, internal oblique, external oblique will be coming over here, internal oblique and transverse abdominis. And fascia transverse towards the lateral aspect is the deep ring over here. So here, these are the aponeurotic part of all the oblique muscles over here. Getting it on? So here, these are the abdominal wall muscles over here, and this part is the only the fascia transversalis part over here. Getting it on? Okay, we'll be discussing it more in detail. So this inferior epigastric artery used as a guide. So if any hernia is occurring lateral to the inferior epigastric artery, that is the deep. What is it? Indirect inguinal hernia. If it is occurring medial to it, that is the direct inguinal hernia. Okay. So here now we are going to discuss the nerve supply of the rectus abdominis. Rectus abdominis is supplied by how many nerves? P7 to P. Okay, lower 6 thoracic nerves. Okay, so lower 6 thoracic nerves will be supplying the rectus abdominis. Why so? Because these are thoracic nerves. How could they be able to supply the rectus abdominis?
Lateral flexion.
Typical, atypical. Based on that. Atypical. Why it is atypical? They will be supplying both the thorax and abdominal as well. Okay, fine. But because of the obliquity of the ribs, the intercostal nerves will be obliquely directed downwards and reaching the abdomen because of this obliquity only. Okay. So the lower 6 intercostal nerves over here, the last intercostal nerve is called the subcostal nerve. These are both thoracic nerve over here. So if you take one of the nerves over here, the nerve will be arising all the way from the spinal cord over here. Okay, so all the way from the spinal cord. Spinal cord, and the nerve will be passing in between in the plane in between. This is the transverse abdominis, and this is the internal oblique. Internal oblique, and this is the external oblique. So the plane in between the transverse abdominis and internal oblique is the plane which will be carrying the intercostal nerve towards the rectus abdominis over here. So now, in between which layers of the rectus sheath it is going now? See here. So this is the absolutely anterior wall of the rectus sheath. Nothing but the external oblique. And then followed by the internal oblique is divided into two lamina. One is anterior lamina, one is posterior lamina over here. And transverse abdominis is giving rise to posterior wall, absolutely the posterior wall of the rectus sheath over here. And if you see, this nerve is passing in this plane and entering in between the deeper lamina and the posterior, what is it? Transverse abdominis aponeurosis over here. You understand? This is the anterior lamina, external oblique over here. This is the posterior lamina and transverse abdominis over here. So in between these two aponeurotic parts, the nerve will enter, piercing the posterior lamina of the internal oblique and supplies the rectus abdominis. Getting it on? So this is the lateral border of the rectus abdominis. This is the medial border of the rectus abdominis. Okay. So the nerve supply of the rectus abdominis is from lateral aspect over here, not from the medial aspect over here. Getting it on? So this nerve pierces the which part, which layer? the posterior lamina of the internal oblique will be pierced over here and enters into the rectus abdominis. Okay. So this part is very much important. It will not pass. It will not be passing in between the external oblique, internal oblique. It will be passing in between trans abdominis and internal oblique. This part is very much important over here, and it is piercing the posterior wall, not the anterior wall of the rectus sheath. And it will be entering through the lateral border of the rectus abdominis, not through the medial border of the rectus abdominis. Understood or not, everybody? Right? This part is very much important. Okay. This is the nerve supply, and here you have seen on it the lateral cutaneous nerve, which has emerged out in this manner, piercing the muscles over here. Could you able to see that? Right? And this part will be divided into anterior branch and posterior branch over here. This posterior branch will be joining with dorsal ramus of the specific nerve over here, and this anterior branch will be joining with the
anterior cutaneous nerve. The anterior cutaneous branch.
Anterior cutaneous branch. See properly over here. Whenever the nerve has entered into the, for example, this is the cavity of the rectus sheath over here. Within this cavity, the anterior cutaneous branch will be emerging outside and supplies the skin over here in the form of anterior cutaneous nerve over here. You know? So this aponeurosis is pierced by this anterior cutaneous nerve, which is a branch from the same intercostal nerve. Okay. The same manner here, the muscular part will be pierced by the lateral cutaneous branch and divides into posterior and anterior divisions or medial and lateral divisions over here. Okay. This will be communicating with the anterior cutaneous nerve. This will be communicating with the dorsal ramus of the same nerve. So dorsal ramus is meant for, generally in case of spinal cord, it is spinal nerve. Dorsal ramus is meant for?
Back muscles.
No, it's not so. Dorsal ramus carries which sensation? Generally dorsal ramus is for sensation, carries the sensation, and the ventral ramus is for motor activity, generally. Okay? Right. So you can understand this is a cutaneous supply, so obviously it is going towards the dorsal ramus, so all the pain sensation will be carried towards the dorsal ramus over here. Could you understand? Yes. Right? You know the difference between dorsal ramus and ventral ramus and everything? Spinal nerve, right? Okay. So, this area of the cutaneous nerve supply for particular thoracic nerve is called dermatome. Dermatome means, this is very much important, dermatome means
A segment which is supplied by a nerve.
a segment.
Which supplied by single nerve.
No, okay, it's fine. A particular area of the skin, for example, dermatome means, this is a spinal cord, for example. If you divide it into multiple segments of the spinal cord over here. So if a nerve is emerging out from a particular segment of the spinal cord and supplying the skin, whatever the area of the skin which is present over here will be supplied by this nerve. So an area of the skin which is supplied by a particular nerve which is arising from a particular spinal cord segment, that is called the dermatome. Skin which is supplied by the segment of the spinal cord, that is called the dermatome. Get it out? So we are supposed to know the dermatomes over here. So what is the need of this dermatome? Okay. Okay. Try to understand this. This is the costal margin and this is the xiphisternum over here, and this is the umbilicus, pubic symphysis and inguinal ligament, for example. Getting it out? So this is the thoracic cavity, this is the abdominal cavity where you can find the umbilicus over here. Okay? So the dermatomes are divided in this manner. Exactly. And followed by 9, 8, T7. And the followed by below will be T11, T12 and L1. Okay. So why these dermatomes are needed, for example? What is the need of this derm term? What is the need of these derm terms, right? What is it? What is it? The somatic nervous system, whenever it is communicating with the autonomic nervous system, okay, so this communication will be indication of certain diseases within the body that will be reflected on the skin. For example, already you have given the question, the cardiac pain is referred to the epigastric region. Why so? Many have written a nice answer. What is that? Phrenic. No. See, imagine how phrenic nerve will be supplying the pericardium and the pleura. Pericardium and the pleura, it is not even reaching the
What was the question?
how the thoracic pain is referred to the epigastric region.
Cardiac, the cardiac plexus supplies the T1 to T5.
Absolutely.
So the sympathetic chain is associated with so T5 to T10. So T1 to T5. Then so thoracic signals say intercrossing will happen, you know.
See, simply I tell you, okay? Simply I tell you. Leave about the thoracic segments, okay? T1 to T4 or T6 to T9, whatever it might be. Leave about it, okay? So simply the pain sensation will be carried by both sympathetic and parasympathetic nervous systems, okay? But in the cervical region, the parasympathetic nervous system and the pelvic region from the lumbar region upwards, okay? The parasympathetic nervous system will be carrying the pain sensation. In between these two, the sympathetic system will be carrying the pain sensation. Do you understand? Okay. Above in the cervical region and below in the pelvic region, the pain sensation will be carried by means of parasympathetic nervous system. In between these two, this entire trunk will be carried by sympathetic nervous system. So whenever cardiac pain is present over here, that will be carried by sympathetic nervous system. The same sympathetic nervous system will be supplied to the epigastric region also. So the pain sensation will be radiated to the epigastric region through the sympathetics mainly, but also can be possible through the vagus nerves also. Can be possible, but mainly through the sympathetic nervous system. Getting it on? So there will be communication between the sympathetic nervous systems over here. There will be overlap of the sympathetic nervous system. Anybody has written this question is answered. So okay, fine. So okay, fine. Let us see it. So in the same manner, for example, let us see it. Come on, everybody. So there is a peptic ulcer. Peptic ulcer means any ulcer within the stomach is called peptic ulcer. Okay, that can be occurring in the intestines also. But let us see that gastric ulcer now present. Okay, gastric ulcer. The pain will be carried to what is that right? Segments. T6 to T9 segments will be carrying the pain of the gastric ulcer over here. Gastric ulcer. So towards the upper aspect of the abdomen, the gastric stomach will be present over here. The pain sensation of the stomach because of the gastric ulcer will be carried to T6 to T9 segments of the spinal cord over here. Getting it on? So if you could able to see, the same segments will be giving rise to the cutaneous supply to this part. For example, this is the umbilical region. So this part of the skin is supplied to the T10 segment of the spinal cord. Getting it on? And above that T9 segment, this part will be supplied by the T9 segment, above the T8 and T7 segments over here. Getting it now? So these segments are supplying the part above the umbilicus over here. And T11, T12 and L1 segments of the spinal cord, will be supplying the below the umbilical part over here. Getting it now? So stomach, for example, roughly it is present over here in this manner. Esophagus will be entering over here. The fundus of the stomach over here. And the duodenum will be coming in this manner. Okay, getting it out? For example, this is a stomach, for example. So this stomach will be carried, the peptic ulcer will be carried by the T6 to T9 segments of the spinal cord. Same pain, okay. So sensation is getting carried by means of this system, autonomic nervous system, sympathetic nervous system over here. Okay, that will be communicated with the cutaneous nerves over here, somatic nervous system. Is it not? Right? So that will be communicated. The same segments will be present over here. T7, T8 and T9 segments are present over here. Could you understand? So stomach will be carried by sympathetic nervous system. The same nervous system is communicating with the somatic nervous system over here, skin supply. Getting it out here, right? So this sympathetic nervous system is communicating with the somatic nervous system over here. Okay. If the pain is carried from this part of the spinal cord, segments of the spinal cord, the same pain will be radiated towards this segments over here. Could you understand? So if the pain is present over here, that will be reflected over these areas of the skin. That is called the referred pain. Okay. So, because of this communication between the autonomic nervous system and the somatic nervous system, if a pain occurs in the viscera, that will be reflected over the surface of the skin in this manner. That is called the referred pain. Getting it on? So, there is a problem in the stomach, that is the ulcer. The pain sensation will be carried all the way from the stomach towards the spinal cord over here. In the same manner, the spinal cord is supplying this part of this skin over here, or the anterior abdominal wall. Okay. So, the pain which is present over here will be reflected over here. Getting it on? So if the patient is complaining of pain above the umbilicus throughout the entire abdomen over here, that indicates that there is a pathology within the stomach or intestines might be. Could you understand, right? So, for example, if there is an umbilical pain over here, only umbilical pain, that will be carried by appendicular pain. So if a patient is complaining of pain in the lower abdomen, that is radiating. Appendix is normally situated in the right iliac fossa. We'll be discussing that later, tomorrow. Okay. Abdomen is divided into 9 regions, abdominal regions. This region is called the right iliac fossa, left iliac fossa, which is also termed as the inguinal region over here. Okay. So this part is the presence of the cecum and the appendix over here. So nervous system which is carrying the pain fibers from the appendix will be communicating with the somatic nerves over here, which is at the level of the umbilicus. So if there is a pain over here, the pain will be felt in the umbilical region over here. Getting it out? Appendix is a deeply seated structure, but the skin sensation will be felt at the level of the umbilicus over here. So the patient is complaining of pain in the right iliac fossa. You can straight away think of appendix. You can ask the patient whether it is radiating towards the umbilicus. If he says yes, so obviously you can almost approach the diagnosis over here. Could you understand? So appendix is deeper, but the skin is superficial. The superficial skin pain and the deeper appendix pain communicate with each other. Getting it out? So in the same manner, if a patient is complaining of pain in these segments over here, generally for the renal colic, kidney, if any stones, for example, ureteric stones or anything, okay, that will be carried by T10, T11, T12 and L1 segments of the spinal cord. Getting it out? T11, T12 and L1 segments of the spinal cord from the kidney over here. The sympathetic nervous system, which belongs to the T11, T12 and L1 segments, will be carried from kidney over here. So because there is a communication with the somatic nervous system, this kidney all the way from the pain all the way from posterior aspect of the kidney, the posterior aspect of the body, will be carried to the anterior aspect over here. Getting it on? For example, I am getting the ureteric stone over here, kidney. The pain will not be present not only over here, but also will be radiating all the way from posterior to anterior direction below the umbilicus level. Because of this communication. This is the sympathetic nervous system communication, the sympathetic nervous system that is communicating with the somatic nervous system over here. Getting it on? So the kidney will be carrying the pain sensation all the way from here to spinal cord, and the same pain will be radiated all the way from posterior to anterior direction through these dermatomes over here. Understood or not? Why the dermatomes are important? Right? So if a patient is complaining of pain in the back, lower back, and that is radiated to the front, and then the skin over here, straight away you can understand that it is probably the pathology within the kidney or ureter on the back side. Getting it on? Based on the radiation of the pain, you can understand. Got it or not? Right? So if there is a pain, so if there is an inflammation within the diaphragm, to which area the pain will be carried? Diaphragm, any inflammation for example, because of the pus collection or whatever it might be, where the pain will be radiated. Shoulder and the neck also, because the phrenic nerve is all the way going from below upwards in this manner. The pain sensation will be carried to the phrenic nerve over here. Isn't it or not? Okay, could you able to understand the referred pain over here? So one important thing about the inferior epigastric artery. What are the branches of the inferior epigastric artery? Whatever you know, inferior epigastric artery branches. Theoretical only, simple. And then, so the inferior epigastric artery branches are inferior epigastric artery branches. Okay, these are first of all cremastric branch. Cremastric branch will be passing through the deep inguinal ring and will be supplying the not cremastric muscle. What is the content of the? I mean, what thing which will be passing through the deep inguinal ring? Spermatic cord. It will be supplying the contents of the spermatic cord. Get it out? So cremastric branch will be supplying the wall of the spermatic cord. Okay, and then followed by pubic branch. Okay, this pubic branch from the inferior epigastric artery will be anastomosing with the inferior epigastric artery. The pubic branch will be anastomosing with the pubic branch of the obturator artery. Try to understand this. This is very much important. This is the obturator artery. This is the inferior epigastric artery. Okay, you could be able to remember where the obturator artery within the hip bone. Where the obturator artery is present in the hip bone. What? Yes. There is obturator nerve. Obturator artery I am asking. What is that? Which foramen? Obturator foramen. Yes. Obturator artery?
Obturator canal.
Obturator canal. Where the obturator canal is present? That is very much important. Anybody sign the hip bone? So, okay. The obturator foramen, which is covered with the obturator membrane, or the upper aspect of the obturator membrane, there will be obturator canal, through which obturator artery and nerve will pass. Could you able to remember or not? Could you able to remember or not? So that obturator artery at the level of the, this thing, right? This one? Obturator canal over here. This is the obturator artery which is going downwards over here. I have already told you, this obturator artery is a branch which supplies the head of the femur. Could you able to imagine now? Could you able to imagine now? No. For example, this is the acetabular cavity. This is the acetabular cavity, so you can understand. Is it not? Right? Here will be the iliopilvic cavernous, and this is the pubic bone, and this is the pubis, and then followed by ischem and everything over here. Okay. This is the obturator foramen over here. This is the obturator canal. Could you able to remember now? Right? So through this obturator artery will be emerging outwards over here. In this manner, which will be giving rise to a small branch that will be passing through this gap and supplies the head of the femur over here. Right? The same obturator artery will be giving rise to one of the pubic branch over here. That is this branch over here. Pubic branch. Both will be anastomosing with each other over here. Okay. So pubic branch of the obturator artery and pubic branch of the inferior epigastric artery, both will be anastomosing just at this level towards the posterior aspect of the body of the pubis. Okay, towards the posterior aspect of the body of the pubis, both will be. This is a pubic branch of the obturator artery and inferior epigastric artery because it is going posterior to the pubis. Okay, so both will be anastomosing with each other, and if the obturator artery is absent, for example, this pubic branch will be replacing the obturator artery over here. Okay, this replacement, that is, in the absence of the obturator artery, the pubic branch from the inferior epigastric artery will be acting like an obturator artery over here. This obturator artery is called as abnormal obturator artery. This is very much important. Okay. So normally obturator artery will be present. In case of absence, the pubic branch from the inferior epigastric artery acts as a obturator artery over here. Now that branch is termed as the abnormal obturator artery over here. This is very much important. Okay, just clinically. Okay. A few hernias we are supposed to remember. Certain hernias you are supposed to understand. What is linea alba? I have told you already. Interlacement of two aponeurotic parts, right? Could you understand now? Right? So interlacement of two aponeurotic parts is the linea alba. So how the muscles will be acting over here? One will be acting on this side, another will be acting on this side. Is it not? External oblique will be moving in this side, and internal oblique will, on one side of external oblique will be moving in this side, contracting in this side, and this side external oblique will be contracting on that side. Is it not? That's why rotation of the trunk will occur. Could you understand? Because this part is the aponeurotic part, this part is the muscular part. So contraction occurs in this manner. Okay, so the trunk will be rotated in this manner. Could you understand? So this part of the muscle will be acting on this manner, in this manner. This part of the muscle will be acting in this manner. Is it not? So if you put an incision for any operation, for example, if you are putting an incision means a cut over the skin. That is not incision. If you put an incision over here, what will happen? What will happen? What will happen? If I am holding the chalkies in this manner, if it breaks over here, what will happen? Obviously, both the parts will be separated over here. So this area will be leaving a gap over here. Could you understand? So if you put an incision in the linea alba in this over here, so this aponeuros will be pulled on that side, this aponeuros will be pulled on this side. So there occurs a gap in this manner. Okay. So the linea alba is split now in this manner. So if the linea alba is split over here, there is a gap within the anterior abdominal wall. So what might happen over here? There is a gap presence over here. Absolutely. The intestines or the peritoneum or the momentum herniating outwards over here. You getting it or not? So this is called, because of the incision, the hernia is occurring over here. This hernia is called incisional hernia. This is very much important. Incisional hernia or incisional hernia. Get it out? This incisional hernia, if the hernia is occurring at the level of the epigastric region, we have seen just a gastric region over here. If the greater momentum is passing through this part, for example, there is a hernia occurring at this level, for example, towards the upper aspect, or in between the xiphisternum and the umbilicus, if there is a hernia occurring because of this deficiency over here, because if the momentum is coming out or herniating out, that hernia is called could you understand? For example, if there is a deficiency over here, the intensities are coming out over here. Because of the incision, the hernia is occurring over here. That is called the incisional hernia. In the same manner, if there is a deficiency occurring at the upper part, towards the gastric region over here, through that gastric things, nothing but the momentum, if it is protruding outwards or herniating outwards at this level within the same linea alba, that is called epigastric hernia, related to the gastric, epigastric region, epigastric hernia over here. So both are incisional hernias only. Could you understand? Right? Both are incisional hernias only, but this is like a subtype, epigastric hernia. Okay, the gastric contains nothing but the not gastric content, gastric things nothing but the momentum. Momentum. If it is herniating through this part, that is called the epigastric hernia over here. Get it out? Right? So there is a term called divarication of recti. Okay, see here, these hernias are very much important over here. Divarication of recti or rectus abdominis over here. See over here, epigastric hernia. Okay, epigastric hernia is over. Divarication of recti. In case of pregnant ladies, because of excessive stretch, because of the fetus, there will be weakness of the rectus abdominis over here. On either side, the rectus abdominis will be stretched. So whenever it is stretched, obviously they will become weak. Could you understand? Okay. So whenever the rectus abdominis on either sides become weak over here, so there will be a separation occurs at the, or there will be weakness occurs at the level of the linea alba. Is it or not? Linea alba initially thick. Whenever the two rectus abdominis will getting separated over here or stretched over here, the linea alba will become thin. Is it or not? Right? So if a hernia occurs at this level because of the weakness of the rectus abdominis and thinness of the linea alba, that hernia is termed as divarication of recti. Okay, that hernia if it occurs, that is the condition is called the divarication of recti. These are very much important. Okay, so because of the incision, there will be a hernia over here. Because of the thinness of the rectus abdominis, if any intestines are protruding out between the two rectus abdominis, in case of weakness of the abdominal wall muscles over here, in case of pregnant ladies generally, that is called the divarication of recti. Getting it or not? Recti is rectus abdominis over here. Divarication. There will be bulging of the rectus abdominis over here. Getting it or not? Understanding or not? Rectus abdominis on two sides, they will become stretched and they will become weak. And the linea alba in between these two initially thick, that will become thin. So that there will be easy protrusion of the abdominal contents into the linea alba over here. Okay, that will not be exposed out, but there will be bulge we can see over the linea alba. Could you understand? So the anterior abdominal wall, if you could able to see a bulge over here, in case of pregnant, post-delivery pregnant ladies, so then you can suspect the condition called the divarication of recti over here. Getting it down? Understanding or not? Right? Because of the weakness of this abdominal wall muscles, nothing but rectus abdominis, and the linea alba also. Get it? So there is a umbilical hernia you would have heard. The fetus, umbilical hernia. Have you heard in the embryology or not? Umbilical hernia? Sorry. Exophilus, absolutely. Exophilus, okay. Right. So in case of acquired umbilical hernia means, for example, congenital umbilical hernia, you know that very well. Is it not? Because of the protrusion of the, what is it? Intestinal contents, that will be intact. But later on, because of the abdominal muscles will become stronger, so the umbilical hernia will be returned back into the intestine, back into the abdominal cavity. That is physiological, normal. But in case of abnormal activity, for example, the umbilicus is the region where a cord will be attached over here. What is it? Umbilical cord. So after removal of the umbilical cord, after the umbilical cord is fallen down, there will be a scar in case of some children. If the scar remains for so long, this scar acts as a way for the intestines to come out. Could you understand? So the umbilical cord which is attached over here is being lost. That is leaving a scar over the umbilicus over here in this manner. If the scar persists because of the infection or any other reason, if the scar persists for so long, the intestines will be protruding out through this umbilicus, leading to the umbilical hernia, which is called the acquired umbilical hernia. Understood or not? Understood or not? Right? So, but in case of adults, there will be umbilical hernia which will be coming out through the lateral aspect of the umbilicus over here, not in the middle of the umbilicus over here. Could you understand? Because in case of adults, the umbilicus will be connected with the structure called median umbilical ligament, which is containing urachus. Okay. So in case of adults, it will be a bit stronger over here. So there will be a fibrous structure attached to the umbilicus. In case of adults, that will not allow the intestinal contents to be protruding out. So if there is an umbilical hernia occurring, it must be supposed to occur by the side of the umbilicus, not through the umbilicus in case of adults. Getting it or not? Getting it or not, right? So there is supposed to be umbilical hernia in case of adults because of the weakness of the abdominal wall muscles over here. That hernia will not occur through the umbilicus, but on the sides of the umbilicus because of the strength of the umbilicus in case of adults. Getting it or not, right? Right. So for example, if there is a incision you have given, parallel to the midline over here, or parasagittal incision you can say that. Okay, over this region. So what will happen? Is there any problem occurs to the patient? There occurs any problem to the patient or not? So if you give an incision over here, that leads to incisional hernia. So if the incision you have given vertically over here, will there be any problem or not? Alright? Scar. Scar nothing, the scar is nothing. Alright? That's okay, fine. So how the nerves are passing, intercostal nerves are passing all the way from back towards the front in this manner, horizontally. So if you put a vertical incision in this manner, so that will be cutting all the nerves which are passing horizontally. So what will happen? There will be paralysis of the rectus abdominis. That leads to loss of all the flexion and everything. Getting it out? So what are the incisions which are dangerous over here? An incision, for example, you are putting an incision parallel to the umbilicus. There is a chance of umbilical hernia in case of adults. Getting it out? So the hernia through the anterior abdominal occurs because of the weakness of the muscles and linea alba, but also because of the incisions what you keep as a doctor. Get it out? So if you keep an incision and if the intestinal contents are protruding outside or anything protruding outside, that is called the incisional hernia. If it is naturally occurring, that is called the either epigastric hernia or divergastrial hernia, whatever it might be. Get it out? So these hernias, if the linea alba and the skin is intact over here, that is called the normal hernia. But if the contents are protruding out through the incision, for example, a person is having anterior abdominal wall over here, you kept an incision. Then it left a gap over here through which the intestines are protruding outwards in this manner. Okay, so this is the herniation through the incision, that's why it is called the incisional hernia. But in case of normal hernia, other than incisional hernia, there will be bulge you can see over the anterior abdominal wall. So this bulge occurs without any incision over here, that is called the epigastric hernia. In case of pregnant ladies, because of the weakness of the muscles, if there is a bulge over here, that is called the divergation of recti. Or if you keep an incision, if the incision is gapping in between the two incisional lines over here, if the intestines are protruding out, that is called the incisional hernia. So there is a difference. Could you ever understand? If you put the incision, through the incision, the actual intestines will be protruding out. But other than incision, if any hernia is occurring because of the weakness of the abdominal wall muscles, so there will be bulging over the anterior abdominal wall. Getting it out? So it is indicating the weakness of the abdominal muscles that leads to protrusion of the anterior abdominal wall. That is called the normal hernias over here, epigastric hernia, divergational recti, or whatever it might be. Getting it out? Right? These hernias are very much important over here. Okay? Understood about everybody? Right? Right, it is.